Good afternoon, everyone. Welcome to another edition of Newton-Wellesley Medical Group Lunch and Learn. We are here excited today, this afternoon, to hear about our lung cancer screening program here from Sean Lear, and also about new guidelines for lung cancer screening. Next slide, please, Sean. Just have one more upcoming Lunch and Learn on Thursday, July 29th, next week, Epic Tips and Tricks. This will be our last one of the series. We will restart again after August on September 9th. So this is our penultimate Lunch and Learn. We are excited about that. We are following the guidance of our Department of Medicine and their grand rounds, which also will have had their penultimate one yesterday, which was a fantastic talk about contact dermatitis. If you missed it, if you can watch the archive, that's definitely something I would catch on to. And we are going to take the month of August back, but we'll be back. Anyone who's heard Rick talk about Epic, you'll definitely learn at least 2 or 3 great tips that'll save you 5 to 10 minutes a day just by listening on this 30-minute call. So please check that out. As you know, all our talks are archived up on YouTube by simply searching Newton-Wellesley Medical Group Lunch and Learn, or also on our intranet Newton under the conferences and education. Next slide, please. 2 quick promo slides. Newton-Wellesley Orthopedic Walk-In is going very well. We are very busy, and we are just making sure our providers know we are open Monday to Friday, 8 to 8. As it says, it's a walk-in. No appointment needed, although appointments can be made, and number is there, 219-1280. We are also open every Saturday and Sunday, 8 a.m. to 1 p.m. Any acute injury, we have x-ray services right on site, as well as casting and bracing, and of course, orthopedic care. Next slide. And then we haven't hit this promo in a while, but over 100 of us have taken advantage of the 1-year free membership for physicians and APPs of the Peloton app. You can still do this and submit your 1-year bill to us. This is this is going to end at some point. You can contact Kathleen Servan. She has more information about this, but basically you go on and sign. You do not need to be a member of Peloton, meaning owning a bike or a tread or anything else. All you need to is have a smartphone and want to exercise. Next slide. And I'll turn it over to you, Sean. You are muted, so make sure you unmute yourself, and thank you.
Great. Thank you, Dr. Snyder. Good afternoon, everyone. I hope you're all enjoying a yummy lunch while I attempt to offer some sort of entertainment. First, I want to thank you all for joining and giving me this opportunity to speak with you today. I'd like to make a public service announcement of sorts. Today, I will be presenting the new updated lung cancer screening recommendations by the U.S. Preventative Task Force. But I would like to make you aware that these new guidelines are for lung cancer screening eligibility are currently under review by CMS. We expect a coverage determination announcement by November 2021, so hopefully sometime in the fall. Some private insurers are covering it on a case-by-case basis with prior authorization. I just want you to keep that in mind. Here is a look at our team. I have the surgeons, Dr. Auchincloss, Dr. Schumacher, and Dr. Geiser, and I'm the physician assistant in the practice. This is how you can refer to our clinic. Epic referral is preferred. An ambulatory referral, or you can call me directly at this phone number or send an email. And I will show you the slide again at the end. So I'd like to start off with a quiz. I'd like for all of you to estimate the percentage of eligible patients who participate in screenings. So first, how many do you think, what percentage participate in breast cancer screening? And if you can, I know you can't, well, you can unmute yourself and speak up, I think, or send it or write it in the notes, or just think it. So for breast cancer, we have 70% of eligible patients participate. What about for colon cancer screening? 60%. Pretty good, both of them. How about for lung cancer? 40% I see. Unfortunately, it's more like 5 to 6%. Wow, right? That's a striking number. As you can see from this slide, lung cancer is the leading cause of cancer deaths, with over 131,000 people dying, expected to die in 2021 from lung cancer. I'm sorry, to get lung cancer, and approximately 235,000 to die from lung cancer. It's the leading cancer killer for men, women, and every ethnic group. And what I want to point out too is we have this stigma that most people who get lung cancer are smokers, but there are approximately 20% of those who get lung cancer were never smokers. So we know lung cancer remains lethal. Approximately 20% of patients survive to 5 years. But if we can catch it early with lung cancer screening, that survival can be greater than 80%. As you know, the NSLT study demonstrated a 20% decrease in cancer mortality with the introduction of low-dose CT lung cancer screenings. I believe no other screening study has shown such a drastic decrease in mortality. And here are the previous recommendations in addition to the new recommendations. So we know lung cancer is lethal, and we know we can decrease mortality with lung cancer screenings. So here we have the current recommendations. Just a reminder again that Medicare isn't covering these screening CTs just yet under the new guidelines, and some private insurers will, but you've got to get prior authorization. So what changed? The changes made screenings more inclusive by including those with less smoking exposure and those at a younger age. So the good and the bad. The new guidelines will increase the number of eligible patients by 86%, which is quite a bit. So by including those with less smoking exposure and those who are at a younger age, we're going to capture a more at-risk population, including women and Black Americans. But unfortunately, lowering just the age and the PACU requirement doesn't account for everything. So we know that occupational environmental exposures increase your risk, such as radon and secondhand smoke exposure, and particularly radon around here. Family history of lung cancer, pulmonary fibrosis increases your risk of developing lung cancer. Like I said before, approximately 20% of patients were never smokers. So we don't screen those at all. And then those who quit greater than 15 years ago. So what I want to point out here is that I want you to notice there's a lower incidence of lung cancers in Black Americans, yet fewer survive to 5 years. So it appears that Black Americans develop cancer and die from it with less smoking exposure, even less than the 20 pack year, the new recommendation. But I think what this points out is that we need to do a better job of understanding what the barriers are to lung cancer screening. And I think what's important to point out from this slide is that lung cancer kills more women than breast cancer, and more than uterine, ovarian, and cervical combined. Women know they should be screened for breast cancer. You see the pink ribbon as a constant reminder everywhere. And no doubt that breast cancer screening is important, but I wonder if we can't do better with our lung cancer, screening our patients for lung cancer. In 2021, they estimate the 5-year survival rate for breast cancer will be 90%. But if you look down here for lung cancer, it will only be around 24%. We can do better. So how are we doing here at Newton-Wellesley Hospital? We started this program in 2015, and here are some of our statistics. As you can see, we have had a steady increase in the number of lung cancer screening exams performed every year up until 2019, and then what happened in 2020? We hit COVID. What else happened in 2020 for our program? We added thoracic radiologists who began very specific, specialized thoracic radiologists who began reading all of our chest imaging, including the lung cancer screenings. We added the lung nodule clinic, and we added 2 new surgeons. So what I want to point out also from the slide is that you can see here that in 2020, we had fewer screenings, but we had more lung RADS 4 captured. Now, those are our really risky patients. Those are the ones that we have a very high suspicion that they have lung cancer. That's almost double the year before in 2019, when we had the most screenings. And if you look up here in this chart, you can see that because of that increase in discovering lung RADS 4 patients, we were able to detect cancer in 24 patients. That's 3-fold the year before. So why do we think this happened? Because we developed a better process. The most important change that we made was what I mentioned earlier, is having specialized thoracic radiologists at MGH reading our studies. In addition to that, as I mentioned, we have 2 new thoracic surgeons join our group to help with the increased number of lung cancer patients who need definitive surgical care. We added the lung nodule clinic so that PCPs and other providers have a destination, a place to refer these patients for management. We have a lung cancer screening navigator, Rosanna Donofrio, who reviews all of the lung RADS 3 and 4 patients. And we purchased a new CT scanner. So I want to show you a couple examples of the language that's used by our radiologists, because I think this is important. As you can see, these recommendations use clear, concise language. There's no ambiguity. They tell you exactly what you should be doing next. And here's an example of a less critical finding, a lung RADS 2. As I mentioned before, we have a lung nodule navigator now, Rosanna Donofrio, or she's been around for a while. And she's been crucial to our program because she not only keeps track of our patients, but she puts all of the data together and makes sense of it. We also have a multidisciplinary thoracic oncology conference that meets twice a month. This conference includes specialties such as pulmonology, oncology, radiation oncology, thoracic radiology, thoracic surgery, and integrative medicine. We all weigh in to make the right recommendation for each individual patient, and we review all lung RADS 3 and lung RADS 4 patients, whether they've been referred to the clinic or not. So Rosanna is the one who's responsible for finding those patients, and she does a great job. And then she creates this chart here for us to review during our conference. And as you can see, she includes all the pertinent information. We review it with the team. We typically have a different radiologist reading the imaging again. So we kind of get a second opinion by having a second radiologist looking at it. And we can also present all the background information too. So we may recommend that you refer, or they, in their recommendations, may recommend that you refer a patient to the lung nodule clinic. And as I mentioned at the beginning of the talk, you can do that through Epic, which is our preference, by phone or email. I manage the work queue on a daily basis, and I go through the patient's chart. I review all their medical history, their risk factors for lung cancer. I go over any pertinent imaging from the past. And then from there, I refer patients, either if I think that they can be seen by me, then I will see them. If I think that they need to be seen by a surgeon, then I make that referral. Pulmonologist, oncology, we're all part of one big team. So I help sort of triage those patients to the appropriate place. And we try to get consults scheduled within 1 to 2 weeks. But if it needs to be sooner, we can do that too. So who can be referred to the lung nodule clinic? We accept both incidental nodules and lung nodule screening patients. You can refer a lung RADS 3 or 4. All lung RADS 3 or 4s can be referred to us. And you can also refer all incidental lung nodules greater than 6 millimeters. But we really don't turn anyone away. So how can we help you reach more eligible patients? How can we capture this group of patients who could benefit from lung cancer screening, which can be life-saving, as we know? I would love to, at this point, open up the discussion to the group and see if anyone has anything they would like to suggest. And that could be for our program itself, our nodule clinic, anything we can do to make it easier on your end for referrals, or any outreach that you think would be great, would be helpful to catch these patients. Here's our information, and I can open this up for discussion now.
Hi, this is Eleanor Polly. I'm one of the hospitalists. I have 2 thoughts. One is I feel like Epic should be able to pull some of this data if it's entered correctly, and maybe even send a form letter to people if they meet criteria, and that they can call your office for more information. And I also wonder if I'm an inpatient hospitalist, and sometimes we find incidental nodules when we're looking for a PE, for example.
Sure.
And couldn't the radiologist kind of I often will get an email of a critical alert. If it's a lung nodule, could they kind of email someone in your group as well, rather than me email the PCP? Or I have to admit, I'm not as good at putting in, I'll have to get better at putting the automatic referral to the lung nodule clinic when they're in an inpatient. But I wonder if we can take out the middleman. I guess that's my point.
Sure. I think that's a great idea. That's something we can look into. I think making sure that we have updated information in their charts about what their smoking history actually is important. So maybe all patients that you see, if it were easy, I know in the inpatient setting, that's not really the case all the time, but if you could do a quick review and ask, and update that information, then that's helpful.
I think, Sean, it's John Snyder. I think, thanks for reviewing this, by the way, it was great. I think a lot of us in primary care, we struggle, with trying to get the patients to do the testing itself. So especially, at least in my mind, the active smokers, I really find it hard to get them to go for the screening itself. I mean, I know you probably see way more active smokers than I do, or maybe not, but I mean, any tricks or tips on that and trying to convince someone who's continually active smoke to go ahead and get a lung cancer screening as well. That's one. And the second thing, and then I'll let you answer, the other thing that vexes us in primary care, which I wanted to ask you about, is, all the false positives, but not only that, the incidental findings that happen when you do these screening tests. We're seeing a lot with the calcium scores as well, where you end up, and you're probably getting a lot of business from the calcium scores, the pulmonary nodules that are being found. So I don't know if you have thoughts about those 2 things.
I think so far, I don't know the data, I guess, but we are getting, when we get those referrals for nodules that are found incidentally, we review them. If we have concerns that they're, and if we're not sure what the management should be, we present them in our lung nodule, in our conference, our thoracic oncology conference. So I feel like we do a good job of trying to weed out those who are trying not to act too quickly, but also not wait too long. That's our process for getting the incidental nodules. And we will get a lot that are probably benign. But then we will catch some of those that aren't, and it will be great to catch them early. And in terms of getting smokers to show up for screenings, I think that we have to let them know that, this is, somehow this is part of their care, right? This is part of their, yes, maybe they feel like they've done something that has caused this, right? Like they're to blame, so to say. If we can get the guilt and take that out of it and say, look, we want you to quit smoking. Yes. If you're not ready for that, that's fine. Let's do the cancer. Let's do the screening. It's your life. I mean, I'm sure you're saying the same things. I don't have necessarily a trick. I don't know if Dr. Geisert has more experience with that.
If I may chime in here, I think we are all in the business of making lung cancer an episode in a patient's life, and that has been possible in many other cancers and not in lung cancers, except when we get at them at very small size. So then the concern is, if we see many patients with small nodules, don't we subject too many of them to unnecessary operations? And my personal experience in the MGH lung nodule clinic that has been in existence since 2012 has me convinced that we don't do that. And of about 630 incidental lung nodules, we took to the operating room only about 105. Of them, 20% had benign lesions. And these 20%, we took them to the operating room because the nodules increased in size. And that was, yes, 20% of the operated nodules, but only 3% of the total number of incidental nodules that we subjected to an operation that was not for lung cancer. And I think that that's important to know. And then the cancers that we removed, 40% were less than a centimeter in diameter. 40% of lung cancers, less than a centimeter in diameter, and almost 90% were stage 1A, pathologic stage 1A lung cancers. And when you look at their survival curve, that's magnificent survival curve that you've never seen before. I've never seen for lung cancer, where these patients go on living and we keep following them, and we may find another nodule and we take this out. There's a class of patients now where we can say, we turn lung cancer into an episode in your life. And that's really what we are about. And that's what I would tell a patient who's still smoking.
It's really helpful, that kind of clarity about that. I wonder if Dr. Geisert or Sean, you would comment on, because we do see, at least in my practice, I see patients who get the first one after the convincing, and then they're hesitant to go back, or they say maybe they'll go back every 3 or 5 years. And I know it's obviously not ideal. I just wonder if there's any data about the yearly screening, or what your thoughts are about that.
Yeah, the initial studies are getting a larger proportion of lung cancers because there's a method to this. In the annual continuing screenings, they get a lower number. But I think once you have your first lung cancer successfully diagnosed at a small size, then I almost want to have to say, we never let you go. Because I never let my patients go as long as they're willing to come for annual CT scans for the rest of their life. I see many of my patients just for follow-up and turn this really into a long-term surveillance system, and it works. And that's what I see as my job. I'm after them to come back for surveillance, even after the first or second operations.
Dr. Phillips has put in the chat room something I was just going to ask about how do you equate the radiation? I know we use low dose to the patients, and how do you counsel them about, if you got a 40-year-old, you're going to be screening them hopefully for 40 years. What are your thoughts about that? You're on mute, Dr.
We are not yet at screening 40-year-olds. And I'm also hesitant in exposing younger patients. But when you have the diagnosis of lung cancer, already, then a CT scan is a measured risk.
Right.
When you don't have a diagnosis of lung cancer, then you should be very hesitant. But every once in a while, every one of us has an anecdote of having seen a patient with locally advanced lung cancer. And when you look back at them, they actually had a CT scan. A 42-year-old patient that I can remember, and 8 years earlier, she had a CT scan with a ground glass nodule. And the ground glass nodule was not followed. And so if you have a ground glass nodule, that is highly likely to be a very early, it's like a colon polyp to colon cancer, ground glass nodule to lung cancer. And if you choose not to follow them, you'll be burned, or no, not you'll be burned, the patient will be burned. And then you have to find in 40-year-old patients sort of a happy medium. You don't have to get a CAT scan every year, maybe every 2 years, as long as you don't forget. The Fleischner criteria, they are not about diagnosing as many lung cancers as possible. They are about limiting the number of CT scans. And their recommendation with regards to ground glass nodules, I don't quite accept, because I don't stop following them at 5 years. At times, I just try to convince a patient to undergo excision of a ground glass nodule so that we can ascertain the diagnosis of early lung cancer or adenomatous hyperplasia. And once we've had that diagnosis, then it's much easier to convince the patient to stick with us and have lifetime surveillance. I don't know whether that answers your question.
I think it does. I think one of the things, people always ask me when I broach a subject with them is they say, well, CAT scan, isn't that a lot of radiation? Which I kind of find amusing, because tobacco use is a lot of exposure also. So I find that question amusing. But anyway.
It is, in that respect, it is amusing. And the modern techniques have reduced in screening CTs the exposure by about 1/3 from a normal chest CT. A normal chest CT has quite a lot of radiation exposure. And I'm very hesitant if I see younger patients for other reasons like pneumothorax, I'm very hesitant in getting a CAT scan. I drag my feet, and I understand that sentiment.
This is Sally McNagny, one of the PCPs. I just wanted to thank you. This is so helpful. And I also want to especially thank, in addition, the radiologist for giving PCP guidance for follow-up, because we just simply don't have time to look up the latest guidelines every time we get a result. So please continue having the radiologist do that. And I'd also, I guess offline, I'll send you a message. I would also love further guidance on screening for those patients with a family history of lung cancer, because I usually just send them to talk to the genetic counselor, but then I don't hear back after that. So that's a separate topic, but I really didn't realize that I should be more attentive with those folks.
I think the thoracic radiologists are very helpful precisely because they use the English language to make themselves understandable. And so when you read their recommendations, they're really very straightforward. They tell you when to look up and they to contact someone and just let the patient be seen. And they tell you when there's something to be followed up. So just read the interpretation. You don't need to read the entire text. And there's rarely any ambiguity in their formulation. I really commend them for having improved the way that they dictate their impressions.
Yeah, and Sally, thanks for saying that. I would have been remiss not to point that out, because as you know, and we struggle with these when we get other readings from radiology, well, we're not quite sure what to do with this kind of pancreatic cyst, et cetera. So that is great. So, all right, we're coming up on the hour. I wanted to thank the team for coming here, and just remind folks we'll be here next week for our last Lunch and Learn. And of course, Wednesday morning at 8:30, we have Medicine Grand Rounds for their last one for the season as well. And I hope everyone gets to enjoy this, hopefully what's going to be a nice weekend. Thanks again. And thanks, Dr. Geisert and Sean, for giving us the talk. Appreciate it.
Thank you, John, for allowing us to present.